Santé publique de Montréal,
From the Direction Régionale de Santé publique de Montréal, or Montreal Health Authority, we have Dr. Mylène Drouin, Regional Public Health Director, and Dr. Carole Marissette Lid, Lead Physician, Harm Reduction and Overdose Prevention.
representing the Oxford House Foundation, Earl Thiessen, Executive Director. Thank you to all of our witnesses for being here. We're going to proceed now with rounds of opening statements in the order listed on the notice of meeting. You have 5 minutes. Dr. Bach, welcome to the committee. You have the floor.
Thank you, and thanks for having me today. My audio okay? You can hear?
Fine. Yep.
Perfect. Okay. Well, I really appreciate the opportunity to come before the committee today, and I just want to thank everyone here for all the time and attention that's being spent on such a critical issue. I'm speaking to you today from Vancouver, where I live and work, and I work full-time in the field of substance use and addiction. And I work in a number of different capacities. I'm a physician, I'm an educator with our fellowship program, I'm a researcher, and I hold some leadership positions. I'm more than happy to answer questions about any of these areas today for the committee. I can speak to our current activities here as far as in treatment and harm reduction and research, education, et cetera. But really what I'd like to lead with, what I'd like to start with is just speaking as a clinician working on the front lines of the crisis. So I want to talk about complexity and how the overdose crisis thing must be conceptualized as a wicked problem. That is a problem that is composed of innumerable complex and evolving issues and needs to be approached as such. I work at St. Paul's Hospital, which is unfortunately one of the epicenters of the overdose crisis in North America. And myself and my colleagues are witness to the scale and complexity and the ruthlessness of this problem and how it's evolved over the past number of years. We see people from all corners of the problems, from all walks of life, from all sectors of society, and we bear witness to the terrible damage that's being wrought by the current toxic drug supply. And we see the uncertainty that touches everyone, knowing how quickly it's evolving and how limited we are and adapt to this. So in practice, that means I watch harm reduction interventions save lives in real time, and I see people failing to be able to access them and suffering the consequences, or see them being asked to solve problems they cannot solve. I see our treatment system, and I help people navigate our treatment system, and I see successful outcomes, and I see those who have been unsuccessful in accessing or navigating our treatment programs, and who have not found what it is that they're seeking for from our current treatment systems. And probably most importantly, myself and my colleagues are faced all too directly on a daily basis with the realities of inequity and how significantly our system as a whole is failing at addressing many of the root causes of substance use and some of the ultimate drivers of the current crisis. I'm all too aware that all the prescription pads and treatment programs in the world are not a replacement for things like primary care and appropriate prevention, appropriate care for physical and mental pain, and fundamental needs like things like shelter and community. So faced with, from that context, from those experience, from that reality, it's just all too apparent to me and my colleagues, and I think really anyone working on the front lines in this sphere, that there is no one approach, no one solution that will address all of the highly specific needs, rapidly evolving needs of every one of these individuals and communities and contexts. It is not possible to frame our approach in such a simplistic terms. So I'm sure that I am not describing anything to this committee today that they haven't heard already or that they're not aware of. But really, the need to conceptualize our response to the overdose crisis as a continuum of resources and approaches that speaks to all of these needs concurrently, that is adapted to many different contexts and variations that we're finding across such a geographically and culturally diverse country. It's inarguable, and I don't think controversial. So really, in summary, for the committee, and like I said, I'm more than happy to talk about any of our activities or our research at length today. But my testimony for you, right, really my plea on behalf of the 20 Canadians that will lose their lives to overdoses today in our country, is that collectively we acknowledge this crisis as a wicked problem, as with the complexity and sophistication that it deserves, and a problem that is nonpartisan, that touches us all, that is an emergency, that is one of the defining problems of our time, but that is solvable. We have evidence-based evidence-based solutions and expert opinions for each of these individual contributors that we can be talking about and implementing if we were all to get on the same page about so many of these challenging issues. So in order to do that, we really must envision our response as an ambitious one, as an emergent one, as a broad and comprehensive one, and recognize that it needs to be adapted and tailored to so many different settings, to so many different communities, and to so many different populations. And in the absence of recognizing that complexity and talking about it with that level of sophistication, we're going to continue to spin our wheels. And I'm worried that the progress that is attainable just will not be there.
Thank you, Dr. Bach. Next, Dr. Henry, please, for 5 minutes. Welcome to the committee. You have the floor.
Thank you and good morning. I'm Dr. Bonnie Henry. I serve as the Provincial Health Officer here in British Columbia, and I also want to acknowledge that I'm speaking to you today from the traditional unceded territories of the Lekwungen-speaking people, the Esquimalt and Songhees First Nations, and I'm very grateful to be able to speak to you today. I want to start by also remembering and recalling that these are our people, our communities, our brothers, uncles, children, colleagues, our neighbors, and poignantly, I have heard from our First Nations Inuit and Métis leaders that too many young people in their communities are being lost to this crisis. Indigenous peoples we know are disproportionately affected due to the compounded ongoing effects of colonial racist practices and structures, including residential schools and intergenerational trauma. And we can't lose sight of that this trauma, this crisis is affecting real people in our homes, in our communities. And we can't lose sight of that as we debate and discuss in sometimes disconnected settings. I want to talk a little bit about what's reflected in the challenges that we're facing right now in this wicked problem, as Dr. Bach described. We know that the number of deaths increased dramatically in 2020 due to compounded effects for a myriad of reasons, the isolation, anxiety that was wrought by the pandemic, the added stressors that we are facing now in our communities around inflation and food insecurity, visible homelessness and poverty, and major disruptions to the global drug trade. And that has led to unrelenting changing toxicity of drugs on the street. And really, I want to make the point that the proximal cause of this crisis is the increased potent and unpredictable drugs on the street. And that is something that is very different than we have faced prior to this crisis. You know, the potency of what is on the street right now is because fentanyl or synthetic opioids have replaced plant-based opioids like heroin, which were causes of problems in the past because it is cheap and it's easy to produce. And I think we do ourselves a disservice when we call what's on the street fentanyl, because it is not. It is a hastily manufactured synthetic drug that has fentanyl-like properties, but produced in uncontrolled conditions and mixed with adulterants. And those adulterants are changing dramatically on an almost daily or weekly basis. We know now that the average concentration in street down or drugs on the street has increased, that more potent drugs means people are more likely to experience drug poisoning and to die, even if they've only tried something for the first time. It's also very unpredictable right now. It changes. There's no labels, no quality control, and current adulterants are making these drugs much more toxic. Things like benzodiazepine-like substances, xylazine, which is another sedative that's used as a tranquilizer, as we know, and non-fentanyl synthetic opioids like nitazines, which are increasingly being found in the drugs. And we also know that stimulants that have been used are now contaminated much more commonly than they have been in the past, and we're seeing that non-fentanyl synthetic opioids are, and sometimes it's from intentional contamination, and sometimes it's because of mix-up and where these drugs are being produced. So things like cocaine and MDMA are actually now much more commonly contaminated with these synthetic opioids that are manufactured in uncontrolled conditions. That is the proximal cause of why people are dying right now. But I also want to focus my short remarks on some of the concerns that we have seen has become a very polarized and sadly political process. First, I think it's very important to recognize that harm reduction and recovery and treatment are not in competition. It is not either or. They are both essential and necessary parts of a continuum from prevention, from understanding what's on the street, to harm reduction, to treatment, to recovery, and includes everything from naloxone, from access to drug checking, overdose prevention services, access to prescription medications for people to get them away from the toxic street drugs, alternatives, and medical assisted treatment, or OAT as we know. I want to refer the committee to the report I released in February of this year reviewing our prescribed alternatives or safer supply program here in BC. It has been submitted to the clerk, but not in time to be translated for this, but it is also publicly available. There's a lot of nuance in there that I think is important for us to understand some of the problems that we are faced with. And I also, in there, is an ethical review of what we're faced with right now and why these programs are so important. I also want to acknowledge that recovery is a spectrum, and I accept that many in the recovery community and many clinicians equate recovery to abstinence. And many recovery homes won't accept people, for example, who are even on medically assisted therapy. I believe this is a false dichotomy as well. We talk to people who have used drugs. The term recovery is not a medical term. It's not about abstinence, but it's a process through which people improve their health.
Dr. Henry, it pains me to do this, but I would ask you to wrap up. You'll have lots of opportunity to elaborate on your opening remarks in response to questions, but if you could bring it to a conclusion, please.
I think I will conclude then by talking about that this is real people, and this crisis continues to ravage our communities, taking the lives of our young people, and that we need to work together on this. I believe we all have the same goal, which is vibrant, thriving, and safe communities, and I'm committed, and my colleagues are committed to working together to find these solutions, not giving in to the discourse that we have seen. The very lives of our family, our friends, our neighbors, and our children depend on it.
Thank you. Suite, la Direction Régionale de Santé.
Continuing on from the Direction Régionale de Santé Publique de Montréal, you have 5 minutes. And you may share your time among you, but you have the floor, Ms. Drouin. Dr. Drouin. Good morning, everyone. Thank you for inviting me. I'd like to thank MP Luc Thériault from the Bloc Québécois for inviting me to appear. As we all know, all of Canada is facing an unprecedented toxic drug crisis, and we need leadership from all levels of government to coordinate an effective response at all levels. This is affecting major cities in Canada, and I spoke with my counterparts from other public health authorities across the country to table a brief with you with some ideas for solutions for which we would need federal help in our provinces and cities to tackle the crisis. For my speech today, I will be focusing on the Montreal area, which I represent. Since the pandemic, we know that the supply systems have changed significantly in Montreal, and we can see it on the ground. To give you an idea, there are currently 86 emergency interventions per month in all supervised consumption sites across Montreal, and that's 6 times higher than in 2020. We have doubled the naloxone distribution in 3 years, and there's been an increase in deaths. It's not comparable to what's going on out west, but we are facing 17 deaths per month compared to 12, and there were 4 deaths per month in 2010. So we can see that this is a very concerning trend. I think that we also need to recognize that there is a housing crisis on top of all that, which is bringing forth a homelessness crisis. All of this put together is creating a dangerous mix for our neighborhoods. So we're facing a crisis that is not solely an overdose one. As previous witnesses have said, it is a toxic, contaminated drug crisis where supply has been compromised. It's not a dosage issue. It's not because there are more drug users. It's really because the drugs that are in the market today are toxic and contaminated with substances such as fentanyl, and unmarketed biodiazepines and other synthetic opioids. affects all swaths of the population, but we need to understand everyone is affected by this. 3/4 of people who died at home. This isn't people who died on the street. Half of deaths in Montreal are people who died alone as well. There are also some recreational, occasional drug users among the deaths, so it does affect groups beyond the it does affect all groups. In terms of our reaction, we are working with the health network, police services, community groups, and the City of Montreal to have a concerted approach to the service continuum that includes harm reduction, treatment, and other components. Treatment cannot be the only option. The full service continuum is important. We need to be able to be proactive and to follow drug use trends on the ground in order to adapt our action plans and strategies quickly with our partners. Treatment and harm reduction strategies must go hand in hand. We know that we're never going to be able to treat all users simultaneously. There are all kinds of variables at play. There are treatment delays. Drug addiction is also viewed as a chronic illness. Some people, when they relapse, are at a greater risk of overdosing. And we know with drug treatments to fight addiction, there are few options available, so that would require additional R&D in order to advance our treatment capacity. At the national level, harm reduction has proven its successes. It has helped with fighting overdoses and the risk of infection. We have reduced, for example, the prevalence of HIV and other drugs in drug use and other diseases rather in drug users. Additionally, harm reduction services is lowering the amount of drug use on the streets and material that is unsafe on the streets for drug use. We are looking at other strategies, such as drugs that work with inhaling. We are also looking at supervised consumption sites and drug tests that help the user determine the risk of their drug use, but also help us monitor and oversee drug use. We also have been carrying out mobile services and festivals because we know that occasional drug users in party contexts can be exposed to lethal drugs. At the treatment level, we have to understand it is only a minority of drug users at the moment that have access to treatment. So we need to be able to broaden our services. Dr. Drouin, I would just ask you to wrap it up soon because you have passed the time limit. If you have a few comments and closing remarks, please say them now. You'll have a lot of opportunities later to explain yourself. Thank you very much. So in closing, we've tabled a few recommendations. This will help us to be more flexible and help reduce red tape. Also, we've mentioned financing for research in certain treatment capacities, but also for additional harm reduction with or without pharmaceuticals. At the end of the day, our response needs to be commensurate with the current crisis we're facing. We must not stand divided. Canadians across the country are dying. We need to stand together. This is a crisis that requires all sectors of society to come together to tackle it, and we have hard scientific data that allows us to target our solutions where they would be most impactful. We cannot afford to fail. Thank you, Dr. Drouin.
Finally, the Oxford House Foundation, represented by their Executive Director, Earl Thiessen. Mr. Thiessen, welcome to the committee. You have the floor.
Thank you, and thank you all the previous comments. It's an honor to be here. I bring a different perspective, the lived experience. I am an Indigenous man, long-term recovery, 16 years. I'm the creator of pre-treatment housing, pure and culturally supportive Indigenous recovery homes here. And we have long-term peer supported transitional homes with no end date. I'm here to provide my lived experience along with professional with battling homelessness and addiction, which for many of us, including myself, means healing. To provide my thoughts on solving the addiction crisis. My unresolved childhood trauma eventually led me to the streets, to being homeless for 7 years. My unwillingness to face my demons and my use of alcohol and drugs, including pharmaceutical opioids, as an emotional response to my childhood trauma were so powerful. The shame of being sexually abused is so intense that many men and women lose their lives to addiction or suicide, refusing to speak about it. We gain knowledge when teaching through words and actions. We heal the same way. The first time I talked about my sexual abuse was while in treatment and doing my steps with a female elder. I cried for 2.5 hours, telling her about my childhood trauma. I walked out of her room a different man. I held that childhood trauma for 25 years. And that's what kept feeding my addiction, right? That kept bringing me back to the same vicious cycle that has progressed into what we're dealing with today. After starting my recovery journey and healing from my childhood trauma, I reconnected with my heritage. It played and plays still a significant part in my healing journey. I'm going to read you a brief lived experience. I want to tell you about a story about a young boy who suffered numerous challenges and trauma in his life. A young boy who grew into a youth who was taught not to show his true emotions. A boy that grew into a young man that had endured so much trauma that he thought he was alone and chose to live a lot of his life just like that, alone. This young man was a victim of sexual abuse, physical abuse, mental and emotional trauma, as well as spiritual trauma. This coping mechanism took the next 20 years of his life. It took his family away. His friends did not want to be around him due to his alcoholism and deceptive tendencies. Eventually, he burned all of his bridges and hurt his family so much that everyone gave up on him. He ended up being dropped off at a homeless shelter because nobody could trust him. This terrified man-child had finally found a place where he was accepted without judgment, without prejudice, and actually thought that this is where he belonged. No self-esteem, no self-worth. This man accepted that this was his destiny. Living 7 years as a homeless alcoholic addict was what his unresolved trauma led him to. A life with no meaning or purpose, no aspirations or goals, and no love for himself or others. After one of the largest losses in his life at the time, his partner of 2.5 years being murdered, he reached a point where he had lost all he was willing to lose due to his addiction and unresolved trauma. On November 13th, 2007, he was arrested for being drunk and disorderly in downtown Calgary. The arresting officers brutally beat him in the back alley. His foot was broken, his eye was full and shut, suffered numerous bruises all over his body. He found he had 11 warrants for his arrest, so he went to the drunk tank to face the Justice of the Peace. He had this opportunity to speak with the Justice of the Peace that morning. He was honest for the first time in his addicted days. He explained that he wanted help, had to help to deal with his trauma, his addiction issues, and help to deal with the murder of his partner. Justice of the Peace asked her name. He responded, Jackie Crazybull. The Justice of the Peace stated he had heard about the murder and offered his condolences. He then proceeded to speak with the devastated and defeated man. He released, I'm going to release you on your own recognizance. I want you to go get the help you so desperately want, and I want you to clean up all these criminal charges. That morning upon his release, this man limped up to medical detox to start his journey towards healing. After almost a full year of treatment and reconnecting to self, culture, and community, he made small goals that turned into huge accomplishments. Today, that little boy who suffered all that trauma, that young man who turned to drugs and alcohol as a coping mechanism, that young man who ended up homeless for 7 years turned his life around and is now the executive director of the very same organization that helped save his life. My name is Earl Thiessen, and I am a wounded healer. Now on to the professional part. Sorry. As an Indigenous leader in Alberta, when it comes to recovery housing, and supporting the continuum of care, I firsthand see the damages of opioid use. In fact, I'm raising my sister-in-law's daughter due to her mom passing from an overdose. In my opinion, the way decriminalization and safe supply is being presented is not the path forward. It's making problems worse. It's prolonging trauma and keeping people in a perpetual state of drug use. In my opinion, safe supply is akin to pharmaceutical colonization. There are other methods, but for the people I serve, the path forward is a recovery-focused path. The biggest thing I can see is we need more medical detox. Withdrawals are horrible. I experienced them. I hit the ground and chewed through my tongue, had 2 grand mal seizures, and then treatment, then recovery. To accomplish long-term recovery, people need all these, starting with detox and treatment, and that's where the pre-treatment housing model came into play due to the wait list. They need peer support, employment, and recovery-focused housing. There is only one sure way to 100% to avoid overdose, and that is not to use. That being said, I fully understand there is a process to go through to get to this point. Saying that one must understand want and need are light years apart. Every person who has addiction needs to seek help, but it's those who want to seek help that actually can and will recover. For those who do not want to recover, we need to provide positive reinforcement and show them through lived experience success stories that recovery is possible. And that they can find recovery, and we pray for them, right? This is all I could do for my sister-in-law. Right. She lost her life. Many people and organizations focus on the biopsychosocial aspect of trauma and recovery.
Mr. Thiessen,
yes.
I'm very sorry. This is powerful testimony. You had 5 minutes, and we're now into the 8th minute. So if you could please wrap it up. As much as it pains me to ask you to do that, there will be lots of opportunity to respond to questions and elaborate on your story.
No problem. Yep. We need to extend that focus further into biopsychosocial, spiritual, and cultural aspects of recovery. We need to look and evaluate all aspects of recovery and having like-minded individuals living in the same environment. In closing, I would like to read the Truth and Reconciliation Commission Call to Action 21. We call upon the federal government to provide sustainable funding for existing and new Aboriginal healing centers to address the physical, mental, emotional, and spiritual harms caused by residential schools, and to ensure that the funding of healing centers in Nunavut and the Northwest Territories is a priority. Thank you.
Thank you all. We're going to begin with rounds of questions now, starting with the Conservatives. Ms. Goodridge, for 6 minutes, please.
Wow. Thank you, Earl, for sharing your truth with us. Thank you for putting a face to trauma and a face to recovery and the power of recovery. I was having to wipe away tears, so thank you. In your statement, you said something that really struck with me, and you said that, in your opinion, safe supply is akin to pharmaceutical colonization. Could you elaborate on that?
Yes, and this is my opinion, right? My people have experienced colonization before, and this to me is exploitation of a vulnerable population, right? It's not getting better. There needs to be a path forward to healing, right? 95% of people that are using, it's due to childhood trauma. And to me and to the people I serve, this isn't the proper approach. It's corralling people. And I don't think that's the way our country should be operating. We did that once, and it's a black eye on our country.
Yesterday, the Minister of Mental Health and Addiction said she thought that decriminalization was a success in British Columbia. Do you agree with her?
No, the approach out there, decriminalization wasn't that approach. Decriminalization for me is to give the person the option to either seek treatment or to accept a charge for the illegal activity that's taking place. The Portuguese model is being altered, I guess you could say, or it's just, in my opinion, it's just not the way to go.
Thank you. Dr. Drouin, nous avons vu...
Dr. Drouin, we've seen recent reports about Maison Benoît Labrède, where young parents and their children need to pass by drug users on the street. And in front of the entrance of that institution, local residents are worried. What do you have to tell them? And do you find that the situation is acceptable? No, indeed, parents are worried. And there's a neighborhood committee to find solutions for this. As I said earlier, the Maison Benoît Labrède is a place for homeless people to stay. There are 2 inhaling rooms for inhaling substances in a supervised fashion for a minority of users. So there's around 10 drug users per day that use that room out of the hundreds of people who stay in that center every day. So there is an interplay between issues here of homelessness and drug use. And we need to identify the correct mitigation measures depending on where these centers are located. We need to ensure that young people and schools have the help they need in order to reduce harm and to lower the issues that can arise as a result. Thank you. Do you believe that supervised injection and inhalation centers should be located right beside a school? There are no standards or regulations around this. I was just establishing a comparison. We often asked ourselves about cannabis when it was legalized. We asked about what would happen there. The issue here is that if we put 200 meters between these centers and daycares and schools, it's untenable. There are so many of these, and we'd have to put them way out of town or next to railroads, for instance. It'd be impossible to put them somewhere appropriate if we had this. However, I agree fully that we need to think about these solutions ahead of time. We need to see how to implement mitigation measures to ensure that cohabitation is possible and unproblematic. We also need to ensure that there is enough supply and sites and consumption sites, because at the moment there's not enough of them, and so everyone is going to the same sites. I'm sorry, we have very little time here today. Would you like to see hard drugs being legalized as it was done in British Columbia? Obviously, in Quebec, we are very aware of the stigmatization and diversion through the criminal courts issues that arise. However, with the City of Montreal, we have started work, and we have deemed that the groundwork and the services available are not there in order to ask for decriminalizing drugs and not legalizing drugs. We need to call a spade here. Do you think that decriminalization, as in BC, would be appropriate in Montreal? Yes or no? I said in the past that yes, it's part of the full service continuum for diverting these people from the justice system. However, we need the right conditions to be in place for it. We are awaiting the results from BC, and at the moment, we do not believe that the conditions are appropriate for implementation in Montreal. Thank you. Do you think that this has been a success story in British Columbia? Thank you, Dr. Drouin. Thank you, Ms. Goodridge.
We're going to see if Dr. Pawlowski's sound is good enough to ask some questions, and if not, we'll go to Ms. Briere. Dr. Pawlowski, you have the floor if everything's working.
Okay, so let's give it a shot. Dr. Henry, in your report entitled A Review of Prescribed Safer Supply Programs Across BC, on page 27 of the report, you actually admit that the diversion is taking place. It says there, it's reported by PSS program staff and clients as a common occurrence. Is my sound okay?
The jury's out. Keep going.
Okay, good. Okay. You'd say in the same report that there is limited data on youth, but it doesn't appear that there's any increased opioid use. And there's to be a supply. I taught psychiatrists who work with the down and out youth.
Monsieur le Président, point d'ordre, la traduction ne peut plus se faire.
Dr. Pawlowski, it was a valiant effort. Madame Brière, you have the floor.
Bonjour et merci.
Good morning. Thank you to all witnesses for being with us here today. Thank you for your testimony that was very touching as well. Committee members, I have just returned from a trip to Vancouver, Calgary, Red Deer, and Montreal. And we had the opportunity to meet with several of you. So thank you for welcoming us. Thank you for sharing your realities on the ground and all initiatives that you are in charge of and leading to fight back against the overdose crisis and the toxic drug crisis. Dr. Drouin, you started talking about the hard data that has been set and established. I'm just continuing your train of thought here, but indeed, we need a full-service continuum, broad range of services, action plans, and strategies to help fight the crisis. If you can add on that. Yes, I believe that Quebec's strategy of fighting overdoses will give good evidence for the strategy to implement. Obviously, we're talking with our partners to understand what is going on the ground. This is an essential component in order to adjust our service offering depending on what arises. I talked about supervised consumption sites earlier, and they are having a significant impact on fighting against overdose and the spread of infectious disease. Also, in Montreal, our supervised consumption sites offer preventative care and offer guidance toward various treatment and reintegration options. I didn't have time to talk about it earlier, but something else that's important is to look at the problem from a broader perspective. We need to look at housing. We need to look at employment. We need to look at social reinsertion. Also, there's the preventative aspect of here for us. And there's a witness that spoke of this as well, but we believe that child trauma and childhood and in general poses certain high-risk issues for further drug use down the road, or for homelessness for that matter, because these problems are often interrelated. We need to work and invest and in order to stem the tide of childhood trauma and help people at that stage of their lives, because they will face additional drug use or homelessness if they have faced trauma. So that is just another part of this wide service continuum. We need to look at it together. It's not just one component that should be viewed in isolation or in lieu of another one, for instance. We need to talk with all available partners who share the same vision and who have enough resources to tackle this crisis, because the crisis is very significant.
I was very impressed by the Road to Recovery initiative at the St. Paul's Hospital, and you said in your remarks that there was no not only one way for the drug user, that we have to suggest or propose a lot of options for them. Could you speak a little bit more about that initiative and what is your goal with it? I think that you would like to open it to all the province.
Yes, thank you for the question, and I'm more than happy to speak about the Road to Recovery Initiative. To the other part of your question, just speaking about options, I think, as has been alluded to by all of the speakers, every individual has a different relationship with substances and different origins, different needs, and those change over time. And so it's really important that we, I think, recognize that diversity and that every individual at any point in time is going to have different needs and expectations, and it's important that we offer that we make that easy to access. So the Road to Recovery Initiative is a new treatment program, a coordinated treatment program that we've launched at St. Paul's Hospital in Vancouver, which is focused on addiction treatment specifically, but really is about again making treatment easy to access. It is challenging enough as somebody dealing with a substance use disorder and many of the other factors that come along with that to seek help and navigate the system. It is imperative that we, as those who are working in the systems, make them as easy to access and navigate as possible. And historically, at least in our province, and I think probably most places in North America, that has not been the case. It has not been easy to access or navigate these systems. They've often been quite siloed and challenging to work through. So the Road to Recovery system is about co-localizing all these various aspects of a treatment system under one roof, such that patients can flow through it seamlessly in a way that they can focus on themselves rather than the navigation itself, whether that's accessing an outpatient clinic, accessing a detox facility, accessing short-term treatment or long-term housing and follow-up, ensuring that all these services work together in one cohesive way so that individuals don't have to spend their time trying to piece those parts together.
Thank you, Dr. Bach. Thank you, Ms. Brière. Suite Monsieur Lemire pour 6 minutes, s'il vous plaît.
Proceeding with Mr. Lemire for 6 minutes. Thank you, Chair, for welcoming me to this committee. Dr. Drouin, congratulations for your testimony and your hard work. I think that you are asking for action on the health determinants and concerted action. Can you talk a little bit more about this? In the context of the overdose crisis, we need to look at factors that arise early on. We need to look at what would lead young people to be more at risk for drug use and look at the overall environment of the child, to look at the socioeconomic conditions, or what we call the structural determinants of health. And so the more that we can allow our young people and Indigenous people to thrive earlier at this stage of life than later in the stage of life to tackle the overdose crisis. We also need to look at harm reduction. At this point, it's less of the matter of the determinants of health, but we are trying to lower the negative consequences related to their drug use. We're trying to offer them a whole bunch of services in order to lower overdoses. Overdoses cause complications. Even if somebody doesn't die from them, it does cause health complications. And then obviously treatment and other services will arise after. So it's a full service continuum, but when we talk about the determinants of health early on, we talk about the preventative aspects that will help us to identify risk factors related to potential drug use and for harm reduction down the road. You spoke of this a little bit, but I'd like to go deeper. Can you talk about how harm reduction is complementary to other services that would support rehabilitation later down the road? Yes, clearly treatment cannot be the only solution here. It can't be a silver bullet. There are so many stories and different stories and upbringings of people that lead them to drug use. There are all kinds of problems as well. There are delays for accessing services, and in the meantime, you need to have harm reduction services to protect people and give them an environment that would lower the risk of death, infection, or other complications. The same is true when we talk about drug use and addiction as a disease. It takes a lot of recovery, tries at recovery and rehabilitation before finally getting there for some people. During those periods when people relapse, well, we need harm reduction strategies to help them. As I was saying earlier, there are no pharmaceutical substances or support for the full range of drugs that are currently on the black market right now. It will be very difficult for a lot of people to have pharmaceutical treatment in order to stop their drug use, given the current field. So for some people, there are very few alternatives, so we need to protect them. And that is one of our mandates at the Public Health Authority. We need to protect the overall health of people in Montreal. And so, obviously, it's not going to be the same treatment approach for all drug users in Montreal. We know that in Montreal, you use various intervention resources, such as resources on the ground, university health centers, and others. This allows for a greater synergy and better results. Can you tell us what this crisis, what the face of this crisis would look at without harm reduction and the variety of services you offer in Montreal? The integration and interplay of services is essential. And I think Dr. Morissette could speak a bit more about this because she has been developing this strategy for decades in Montreal, actually. And this cooperation helps us to work with all partners to understand the situation and to evolve our service continuum. This is the most blatant need right now. We need to be able to evolve. We need to be able to offer new services. And if R&D offers new solutions, we need to be able to implement them with institutions like the CHUM, the Centre Hospitalier de l'Université de Montréal. We need to be reactive, and we cannot let ourselves be surprised by new drug trends. Dr. Morissette, did you want to add something? Yes. Harm reduction. Without harm reduction and supervised consumption sites, we would have had a lot more deaths than what we have right now. So we know that these help save lives. If we want to meet the urgency of the crisis, we need to develop these services additionally. We need to view harm reduction not as a problem, but as a solution. We need to add more services and diversify these services. We also need to grant access to housing for drug users. We know that when people end up homeless, well, the first step toward rehabilitation is housing. And this would really be the first step towards all kinds of good things, such as reducing their drug use and even stopping their drug use. These strategies must not be pitted against each other. They must be viewed in its entirety.
Lemire.
Thank you, Mr. Lemire.
Johns, please, for 6 minutes.
First, I want to thank all of the witnesses for their important testimony and the important work that they all do. We heard from the Chief Coroner of British Columbia, Bonnie Henry, Dr. Henry. You're the Chief Medical Officer of British Columbia, the BC Chiefs of Police, and the Canadian Association of Police Chiefs, the First Nations Health Authority in British Columbia, and the BC First Nations Justice Council, as well as the Health Canada Expert Task Force, all saying that this is a complex issue that requires a comprehensive response. And every single organization and individual I listed there was clear that we need to replace the toxic street supply with a safer supply of substances, to stop criminalizing people who use substances, create a system with treatment on demand, invest heavily in recovery, prevention, and education. Dr. Henry, we just had the decriminalization model in British Columbia come into effect in January of 2023. And the month prior, the death rate per 100,000 per day, was 7.5. The last 2 months, the death rate dropped to 6.1 and 6.2. Do you believe that the decriminalization trial in British Columbia is working and has been working?
Thank you for that question. And you're absolutely right. We need to focus on what this is. It's one of a suite that we have heard is necessary. And the decriminalization of people, and that's the important thing. It is about removing criminal penalties for possession of small amounts of controlled substances. It is not legalization, and it is not a free pass to violent or threatening behavior. And it is not the sole solution. It's one important tool to help for a couple of reasons. One is the people who are visible to police, and we see that, and that is what a lot of the focus is on. People who it's uncomfortable for us to see people who are on the street, who are homeless, who don't have a safe place to go to use their drugs or to connect with people. But it also is important for those who are not visible, who are also dying, and we've heard that this morning. Young people who are maybe experimenting or occasional users, the young man who's working in the trades, whose family I hear from all the time, didn't know that he was using drugs again or didn't know that they had relapsed because of the shame and stigma and fear of a criminal record that keeps people from talking about their drug use and reaching out for help. So in that sense, yes, the decriminalization of people here in British Columbia has leveled the playing field across the province so that it's not discretionary about who gets their drugs seized, who gets a criminal record. And we've seen that. We've seen that in the statistics on drug seizures and on charges for people who use drugs.
Dr. Henry, you've been the Chief Medical Health Officer since 2014. In 2014, there was a death rate per 100,000 of 7.9. It skyrocketed to 30.3 in 2017, just over 4 years under the Christy Clark government. Since then, it has gone up as high as 46.2 and now at 40.3, a 33% increase versus a 383% increase under the Clark government. So when you hear politicians throw out anecdotes that they blame safe supply or decriminalization for the causation of the spike in the toxic drug crisis, can you explain the harm that might cause? And I will cite that Alaska's death rate went up 45% last year without decrim, without safe supply. Alberta went up 17%, Saskatchewan 23%. Baltimore has a death rate of 190 per 100,000 versus 40 in BC without decrim, without safe supply. Can you talk about the importance of peer-reviewed research instead of anecdotal policy?
Well, thank you for bringing that up. And I think it is important to recognize that many of the issues that we're dealing with, and we've talked about that, are related to underlying concerns and issues that people have. We know that when homelessness goes up, when poverty goes up, when income insecurity, inflation, all of these things drive anxiety, mental health issues that lead people to increase substance use. So it is important for us to look at data, to look at what is it that supports people across the spectrum of people who use drugs. And so I think it is important for us to not focus on one single thing, one particular thing, and try and make points or political points, because it is harming those who we all, I believe, want to include in our community and to help find their way to their road to recovery.
Dr. Bach, you worked really hard on an evidence-based and expert-led project there at Road to Recovery. Can you talk about the harm the disinformation causes to you and your team and the work that you're doing on the front line?
Absolutely. I work with tremendous colleagues in my institution and also all across Canada. I think there's really good people who see viable solutions and are working towards them. I can say that as I mentioned in my remarks, that seeing many of these complex issues really oversimplified and to be frank, often made to be such political issues, it's really challenging for those who are working on the ground who do all work alongside one another, despite many differing opinions, who do see that complexity and that need for different responses in different contexts. To see this turned into something that has become a political issue. It's very challenging. It's very distracting. It's very demoralizing, and I think it really prevents us from really talking with the level of sophistication that these topics deserve.
Thank you, Dr. Bach. Next, Dr. Ellis, please, for 5 minutes.
Thank you very much, Chair, and thank you to all the witnesses for being here. It's interesting, Dr. Henry, one of our colleagues perhaps started asking you this question through you, Chair. Dr. Henry, you've said multiple times in the media that diversion is happening. Is that true?
We have to recognize that this is a symptom of unmet needs, and we know that there are many different types of people sharing their drugs with others who don't have access to systems. And so we have heard that this has happened. It's happened before. We had our
thanks for that, Dr. Henry.
And it
thanks very much.
Happen.
So diversion is happening. We know that. The question is, the leading cause of death in children 10 to 18 in British Columbia is, could you remind the panel what that is?
It's the toxic drugs that are on the street right now.
It's overdose, is it not, Dr. Henry?
It's the toxic drugs that are on the street right now.
So you can tell this panel equivocally that no so-called safe supply is part of the overdose deaths in 10 to 18-year-olds in your province.
Well, you will have known that the chief coroner just put out a report on that this week. And while hydromorphone, which comes from a variety of different sources, was there in a small percentage of young people who died, it was not the sole substance found and was not the cause of death. The cause and the challenge.
Thanks for that, Dr. Henry. You know, the big thing, excuse me, Dr. Henry, what do we do know is that hydromorphone has been found in 10 to 18-year-olds who have died in your province due to overdose. That's disturbing to me.
Has not
I don't think that I asked you a question, Dr. Henry.
Dr.
Henry, excuse me. This is my time to ask you questions, so please, if you would be respectful of that and answer the questions, that would be incredibly helpful. When we talk about legalization, has the import and supply of heroin ever been allowed in Canada?
I'm not sure what the question is. Are we talking about legalization?
Well, we probably should be, because I believe in your statement, ma'am, you've said what we're doing with legalization around cannabis, et cetera. You also talked about monitoring safety of the product. So in the long term, that would be a way to counter the toxic street drugs and take away business from organized crime. Absolutely. So it would appear from that, ma'am, that you are a supporter of legalization. Is that true?
I think what has got us into the situation that we're in is prohibition, and we've seen that in many different situations over time. So we saw that with alcohol prohibition, we see this with cannabis, and I think legalization and regulation minimizes harms.
So you would be a supporter of legalization of hard drugs such as opium, heroin, cocaine, methamphetamine?
I don't think the term hard drugs is a term that
I don't think that I asked you that, ma'am. What I asked you is, would you be a supporter of legalization of hard drugs such as methamphetamine, cocaine, heroin, and opium? Would you support that?
I believe that legalization and prohibition is the cause of the issue. So legalization and regulation minimizes harms of all drugs.
Is that a yes or no, Dr. Henry? You're being very obtuse in your answer.
I'm not being obtuse. I'm being truthful in what I believe, which is that prohibition is one of the causes.
So the question is, Dr. Henry, is would you support legalization? I'll ask you the third time.
I support legalization and regulation of drugs to minimize harms.
Do you know of the business called Fair Price Pharma that exists in your province?
I know of it.
And do you know that Fair Price Pharma arranged for the importation of 15 kilograms of heroin into Canada?
That would be under the Health Canada regulations.
I didn't ask you about the regulations. I asked you if you knew that they imported 15 kilograms of heroin.
No, I did not.
Thank you. Do you know a person named Perry Kendall?
Of course I do. Perry Kendall was the provincial health officer in British Columbia.
And have you ever met with Mr. Kendall?
I meet with him regularly.
And is it true that he is the founder of Fair Price Pharma?
That's not correct.
That is not correct. Oh, okay. Fair enough. Does he have any relation with Fair Price Pharma?
Not that I'm aware of right now.
Has he had in the past?
He has had in the past, I believe.
And so he was an official in your government, not that you're the premier there, but he was an official in your government, and now he runs a company which has imported heroin into Canada. Is that true?
No, that's not correct.
That's your time, Dr. Ellis. Thank you. Next, Ms. Sidhu, please, for 5 minutes.
Thank you, Mr. Chair. Thank you, all the witnesses, for being here with us. Before I start my questions, Mr. Thiessen, I wanted to recognize you for your bravery and strength. Thank you for sharing your story with the committee today. Dr. Henry, my first question is to you. You're known to most Canadians for your response to the pandemic in BC. Could you talk to this committee about the impact this pandemic had on the mental health, especially on British Columbians?
Thank you for that. And I think that is one of the challenges that we face that is most critical. And I'm particularly concerned, and have been for some time, the data has shown that the issues of mental health and anxiety in young people in particular has gone up dramatically through the period of the pandemic. And while we have seen some recovery, there are still higher rates of anxiety and mental health issues for young people. And we know when those issues increase, that we know many people turn to substance use to help support them in their world. And so we've seen an increase in substance use, and not yet substance use disorders in young people remain low, thankfully. And we have not seen an increase in that over the past number of years. But what we have seen is increased use, occasional use, challenges in people who have problems accessing mental health substance use support. So those are the issues that we really need to focus on right now, is a broad spectrum of how do we support young people to recover from the traumas that they've been through over this last few years.
From a public health perspective, do you think forced treatment is a good idea?
Well, data has shown over the years that if you force treatment or a treatment that's done when people aren't ready can leave them more at risk when they have relapses or when they leave treatment, and it undermines that relationship that they may have of trust, particularly with their healthcare providers. And we know that and we say this all the time, the opposite of addiction is connection. And to having a trusting relationship with your healthcare provider is what I hear from people that they crave and that they want and that they need to help them on their road to recovery.
My next question to Dr. Back or Mr. Thiessen, you can answer that too, about stigma. What recommendation or examples of successful policies can you give to this committee to address stigma in British Columbia or across Canada?
I can speak to that more in the sense just of how much I see as a physician, as somebody working on the front lines, how stigma does impact the way that we provide care for people who use substances, and accordingly their willingness to access care. It is very rare that I see a patient who hasn't experienced stigma related to their substance use, whether it's from friends, family, workplace, or the healthcare system, and we can't ignore how significant of an impact that has on people's willingness to be forthcoming with their substance use and to seek help and to find and have trust in that health. As far as specific policies that have been successful in addressing stigma, I'm not sure that's something that I have to give some thought to, and I can't really speak to. But I think it's unfortunately it goes much deeper than any one specific policy. This is about a cultural shift in the way that we think about substances and substance use disorders and people who think about substances. This is a process and something that I think really must inform every discussion we have and every intervention we're talking about, because in the absence of really addressing that as one of those fundamental upstream drivers, we are going to continue to struggle.
And Mr. Thiessen, you want to add on that?
Yeah, that's a very good question, and that is a huge driver right now in society in general, right? And for me, stigma and shame go hand in hand, right? I notice and it plays both sides, right? Right now, there's a huge stigma towards recovery, right? And I've had a lot of people, when I was addicted, stigmatize me and everything, and the way I see it now, and the way I speak to people that are on the cusp of entering recovery and everything is other people's opinion is really a rotten way to live your life. It's your opinion about yourself, and I think changing the societal shift in how every aspect of a recovery-oriented system of care is viewed shouldn't be stigmatized. It's hurting more than anything right now, right? Shame is a huge feeder of addiction, so and those coincide with each other.
Thank you, Mr. Thiessen. Suite, Monsieur Lemire, pour 2 minutes et demi.
Proceeding with Mr. Lemire for 2.5 minutes. Thank you, Chair. Dr. Drouin, can you talk to us about the regulatory obstacles that the federal government could remove in order to streamline the process to help community organizations and others to ask for and deliver exemptions for supervised controlled sites and for drug analysis sites, and especially why are these regulatory borders there? I will let Dr. Morissette answer this question. She manages all the bureaucracy. Yes. Here, the point is that we need to have an exemption to the Controlled Substances and Drugs Acts, whether for a supervised consumption site or a supervised inhalation site. We are at a point where we need to improve, increase, and diversify services, so we need less administrative burden in order to develop additional services, particularly for supervised inhalation sites. We know that there is we know that it's a very strict process. All partners are working hard to satisfy the criteria of the regulations, but to streamline the whole process would be a step in the right direction. Drug analysis is a must to fight the toxic drug crisis. Can you talk to us more about the efficiency of this kind of measure and what would be needed to make it even more efficient and effective? I'll start it off on this one. Drug testing has a lot of purposes. First of all, it allows drug users to assess the risk of the drugs they're taking. In addition, it allows us as public health authorities to test various drugs to see what exactly is on the streets at the moment, and then to be able to adapt our strategies for harm reduction as a result. As I was saying earlier, a lot of our sites are being diversified. We are offering drug testing in our supervised consumption sites, but we're also offering it in festivals. This is because young people go to these festivals and they often do drugs that could be contaminated. So we also use drug testing at festivals in order to prevent overdoses, especially because we're talking about occasional drug users here. Thank you, Dr. Drouin. Thank you, Mr. Lemire.
1.5 minutes.
Well, thank you. I think I'm going to ask Dr. Bach, can you talk about the road to recovery model and care at St. Paul's, and maybe just, I know some of the committee members have been there. I've been there to meet with you and your team and have a visit and better understand the work that you're doing. But you could talk about your model versus the alternative, versus, status quo to the alternative that you're delivering. And also, can you talk about the gaps and opportunities in the medical education landscape within Canada and how addressing these may also help to build our workforce for physicians to respond to this crisis with quality addiction care. You got about 2 minutes. I'll give you the rest of my time on this round.
Certainly. Those are two excellent questions. I already discussed briefly the Road to Recovery model at St. Paul's and Embroidered. We were very happy to host some of these members there. And once again, we're talking about a coordinated model of care where essentially the essence of it is making, there's already a question here about forced treatment or course treatment. We have not traditionally done a particularly good job in Canada at making treatment easy to access, just easy to participate in, easy to access, easy to navigate, patient-centered, flexible, coordinated. Before starting more conversations about forcing people into treatment, I would suggest that we could start by trying to make it appealing and attractive and speak to people's individual needs and goals and situations and just make treatment easy. So again, the Road to Recovery program is about coordinating a whole host of services under one umbrella so that patients can enter at different points, can move through it in ways that that speak to their particular needs and their trajectories, which are seldom linear, as we know.
Dr. Bach, sorry to interrupt. Just do you think it's almost premature to even have that conversation about mandatory treatment when people who want help can't even get it anywhere in Canada?
I would suggest yes. I would suggest that we need to be focusing on making treatment available and easy for those who are asking for it, and that's a bare minimum of this. It's the bare minimum in terms of where we can start. Moving to your second question, which I think is a really critical one and one we don't talk about enough. One of my roles is as the director of our fellowship program here, which I'm very, very privileged to sit in, and we train 10 fellows per year approximately at St. Paul's. So that's 10 addiction medicine experts per year. Unfortunately, that's about a third of the capacity for the entire country coming out of our center. We simply do not offer a lot of training opportunities for people who are really seeking, if in the medical field, who are seeking to work in this space. And so when we're talking about increasing access to all these services, we really do need to be mindful of our workforce and really look at ways of incorporating opportunities for education for any number of different health professionals, and really making that education available. In the current climate, anyone who is seeking further training or education in this space must be able to access that. Like that is if somebody's actively wanting to do this work, it's the least we can do to try and facilitate that exposure, that training, whatever level that might be. So in order to build that workforce, because
Thank you, Dr. Bach. Next, Ms. Goodridge, please, for 5 minutes.
Dr. Henry, I was wondering if you could tell us how many publicly funded treatment beds are in British Columbia.
I don't have that data, but I can get it to you.
The answer is 3,663. Sorry. Do you know how many people are prescribed safe supply in British Columbia?
The last we checked, the Prescribed Alternatives program had about 4,000 individuals.
So do you think that it's appropriate that there is easier access to drugs than to treatment?
I don't think those are in competition with each other. There are things that work together, as we've heard about. We need a suite of things, and people accessing pharmaceutical alternatives, we know that from the data, and I refer again to the report that I put out. We talked to a lot of people about this, and the most of the prescribed alternatives are being used in combination with OAT. So that is people being able to get into treatment.
What's the average wait time for someone to be able to get into detox in British Columbia?
Well, that would vary, and maybe Dr. Bach would be able to give you more details around that. But it varies, and one of the
Dr. Bach, if you can answer that would be great.
Certainly, it's going to vary tremendously depending on needs. Part of the Road to Recovery model has been streamlining that access. So for people who are deemed high priority, it's 24 to 48 hours for those who, and certainly can be longer for those who there's a prioritization process. But for anyone high risk, youth, youth, people high risk of overdose, generally within 48 hours in Vancouver Coastal Health at least.
According to the RCMP in British Columbia, nearly 2/3 of the detachment served communities do not have drug rehabilitation or treatment programs available. Do you think that's acceptable? Dr. Henry?
Of course not. We want access to treatment programs across the province, and we've been working to scale up that access as programs that Dr. Bach mentioned, for people to be able to access them anywhere in the province and have remote support, for example.
Do you think that decriminalization has been a success in British Columbia so far?
I think parts of it certainly have. With any change in policy that's like this, there are always unintended issues that come up, and we need to be pragmatic and address those.
So you think that having a record number of overdose deaths in the first year of a pilot project and